I want to thank everyone. Dr. Lee, if it's okay if I start, is that okay?
I'll give it just a few
Oh.
minutes for just a minute for everybody to start rolling in, and do let me do a little bit of housekeeping ahead of
Sure.
time. Okay, we have the participant clicker is moving up. This has been an interesting month for the Alliance, and I'm very happy to be able to be here today. It would have not been the case several weeks ago. So this is our webinar tonight is Surgical Perspective, a molecular adjuvant to ruptured brainstem cavernomas. And this is Dr. Sudhakar Vadivelu who's speaking with us this evening. I will introduce him, but first I want to say, if you have questions for him, he will be here a little while and we'll be able to answer them. I ask you to put them into the Q&A. You'll see on your screen, it says Q&A, click that, type your question. It's much, much easier for us to see them there and curate them there. If you put them in the chat, there's a very good chance that they will not get answered. If you're having other issues aside from questions, feel free to put that in the chat and someone will try to help you during the course of the meeting. So after the meeting, there will be support group as usual on Thursday evenings, and we will drop the link to the support group into the chat toward the end of the group so that you can just click through and get into group. Dr. Vadivelu, I'm very pleased to have him here. We've known each other quite a while. He is the medical director of the Alliance to Cure's Center of Excellence at Cincinnati Children's Hospital and Medical Center. And he's also the director of their Pediatric Cerebrovascular Disease and Stroke Center. He is a pediatric neurosurgeon and he's trained in both endovascular and open surgery. And his big interest is in treating vascular disorders of the brain and spinal cord in children. And I welcome you here today, and we're really excited to hear what you have to share with us.
Thank you very much, Dr. Lee. I think this is quite an opportunity. I think these webinars are so well done through the Alliance to Cure. I think the opportunity to bring together researchers, physicians, patients, families all together in one virtual room and to be able to ask questions and learn from each other is so important. So I think the idea of learning from each other is a key component, or I'll say an objective going forward with this talk. So here, as you can see from my title slide, surgical perspective, I am a neurosurgeon. I do both open and endovascular, but as you guys know, cavernous malformations, they're angiographically occult. So here, we're going to talk about the surgical perspective and really what I think is novel but not surprising, if I could put it that way, a molecular adjuvant to ruptured brainstem cavernomas, but in particular here, pediatric brainstem cavernomas. With that, I'm going to move right along here. Bear with me for transitioning of slides. There's a couple things that I do want to point out. Number one, I'm hopeful that you'll consider these three learning objectives in kind of a loose fourth. Number one, there are molecular adjuvants that are out there or medical therapies. And how do we know this? You've heard from Dr. Awad. He's given a great overview a few different times, whether it's at the national meetings or through webinars through Alliance to Cure, really given an overview of a lot of the current cutting edge research where we talk about medical therapies that could be very good for prevention of cavernoma development, prevention towards cavernoma rupture, and moving forward. So we're hopeful that someday and age that this will come together and be a great resource for the idea of prevention with medical therapies. But nonetheless, when we have a cavernoma, we think currently the standard of care, if need be, is surgical resection. And so the thought here is that how can we do this better? So I want to leave you with that concept in your mind. And one way to consider this is what we've recently been doing here in a collective approach is using Propranolol as a molecular adjuvant. So I want to talk to you about some of the limited research that's out there from both basic science studies looking at the molecular aspect and the clinical evidence of Propranolol use for cerebral cavernomas. I'm hopeful that you'll get to see some of our experience with the application in ruptured pediatric brainstem cavernomas. And then third, I want to give you a little bit of a glimpse of some of the research that we're doing here, translational, with mine and Dr. Gao's labs, to look at the idea of cavernoma modeling and how this translational effort with you there in the audience and the research going forward can really come together from a standpoint of benchside research to bedside application. So one of the first slides, and I'm really proud to put this slide in and very recently, is this book that's now recently published by Brianna Wolf, one of the moms of one of our children that we've taken care of here, about Julianne or Juju, and her story about a brainstem cavernoma, ruptured, and her trial and pathway going forward to recovery. I think the big thing from this book is not just the ability to get a glimpse of what the family thinks, but also what Juju thinks. Some of the experiences and some of the things that she does, both out of the hospital and in the hospital, is so grasping to learn from. And so I'm hopeful with this slide, you're going to learn a little bit more from this presentation, but maybe even from our own pediatric patients and how that may be helpful going forward. I don't want to share or give away everything that's in this book or the big things that I like about it, but there is one particular aspect that I thought was so helpful in this talk that I had to add it going forward. And this is that loose fourth objective, which is grass soup. And I would ask to those of you, and maybe at the end in the chat box, what you think about grass soup, but it's the idea for Juju to be out and playing in the yard. And this is my PowerPoint animation or caricature of grass soup, but taking grass and the world around us and putting it in a bowl, taking a spoon, the idea that we can discover things using the resources around us, the environment around us currently, to make that goal happen, which is the fun and play that Juju was doing before she encountered these severe events with her brainstem cavernoma. So consider grass soup as that loose fourth objective going forward. You know, I think we all have to recognize where we are with brainstem cavernomas, and it's not hard to see that I've selected a few different studies that really talk about a large collection of patients. And this first slide really goes over the idea of the natural history of brainstem cavernomas. So really the idea of what is the hemorrhage risk going forward? So even in the adult patients, can we see that there's a superficial location or DVA may be considered as independent risk? But what I really want to highlight is this idea of approximately 51% hemorrhage risk over that 5-year cumulative risk. If we look at children with cerebral cavernomas, we can identify that brainstem cavernomas, or that location, has identified as a possible higher risk for hemorrhage when we think about this, and even up to 30% risk, respectively, and cumulative over time. And in a similar fashion, we can identify that a brainstem location, the annual hemorrhage risk might be that close to 12% in that location for pediatrics, but then at the same time, a high rehemorrhage risk of up to 33%, and individual factors that may be associated. Maybe it's a large size to begin with. Maybe it's the perilesional edema effects. And so that's what I really want to point out here or underline. And when I tell a lot of families, when I talk about edema or swelling, to use that word synonymously, it's kind of like saying this crude example of being punched in the eye, and I hurt here and I feel the effects here, but over time, later on that evening or in the following days, I'm going to get swelling or change of colors and things to see. And so how can we control some of this effect going forward? Can we actually control the lesion itself moving forward to help us? But nonetheless, these are just gross numbers that we can extract from the literature or the natural history. So what happens when we're going on to treatment, surgical outcomes? Well, in some of the large series, we can see here that there's a rebleed risk even after surgery of approximately 0.5% to 5% in these large series. And there could be a new neurologic deficit of 48%, and almost synonymously or similarly, a permanent risk of the 21 to 25%. So these are pretty severe. Brainstem cavernomas with hemorrhagic ruptures can be pretty disturbing going forward. So one of the areas of interest that we have with pediatrics, or at least that I have, in trying to do better. And so when we talk about pediatric brainstem cavernomas, we might even think that a time of a second look surgery may be beneficial with cerebral cavernomas, but brainstem presentation may be the ones that are associated with even the worsened initial neurologic outcomes. So no matter which way we tend to try and tackle this, and over time with different approaches, we tend to get similar results going forward. So much like being in a teaching hospital and the idea of having residents and fellows, we always talk about our cases and how things can be done better. When we walk out of a room or walk into a room, we say, can we do better? And that's, I guess, the underlying theme here that I'd like to present to you guys. So even when I look into the literature and going forward, where are we and where can we go? Here's an interesting case, at least that we found interesting here, is that published in Surgical Neurology, the authors there had talked about a young infant, very young in age, 2 to 3 months, who had repeated hemorrhages, 1 to 2 hemorrhages while in the hospital, managed conservatively, went on to have mild symptoms at the time that they called cranial neuropathies. And I want to caution that there to begin with. And I'm not sure how well this shows up on your screen with some of the dark image, but you can see here a brainstem cavernoma that I'm highlighting with my laser pointer. But then additionally, where this orange arrow is this large extracranial neck mass found to be a lymphangioma. So another malformation, but not a cavernoma. And so given time with the repeated hemorrhages, we can see that brainstem cavernoma has enlarged significantly and went on to require ICU admission, respiratory distress, weakness, significant cranial bulbar palsy. But I want to go back to the management and the mild symptoms, which in an infant are very hard to discern. You have a young patient who's still developing their neurological exam. And so the idea of having a hemorrhage that we might be able to say is severe, causing us lethargy, having significant cranial neuropathy, are things that we would be able to express, but in a young infant, difficult to discern. So sometimes even the mild symptoms are difficult to say that they're truly clinically mild or perceived to be mild. So nonetheless, went on to a third hemorrhage, which was pretty significant. And the surgeons there did a great job with a telovelar, meaning back of the head, underneath the cerebellar hemispheres, going in through the fourth ventricle and removing this hemorrhagic cavernoma, with a great radiologic result. And so the patient kind of follows along what I was presenting with, going away from the natural history to now the surgical history, and being discharged from the hospital 2 months later with a tracheostomy and some recovery of exam, which was great, but still significant concerns for this child going forward. And I would say, again, boy, these are complex cases. How can we do better going forward? And that gets us to the next slide. And that's just, can we do better? It's now, how can we do better? And so I think if we were to really think about that case, which I think it represents a number of different factors, I want to go back to it and say, well, what happens if this cavernoma did not hemorrhage and we didn't have symptoms and we were treating this lesion here? Is there a possibility in the modern era that we would be using propranolol, which has come into play as a standard treatment towards hemangiomas extracranially, and here would be a significant consideration in this young infant? And so could that have been helpful even for the brainstem cavernoma? So could we do better moving forward in this day and age? So with a randomized controlled trial for propranolol, I want to focus here on this medical therapy as the molecular adjuvant, meaning, is this a medication not in comparison to surgical outcomes, but can this be helpful for our standard of care or our surgical treatment going forward? Is there a role for this? And so here, in the most severe cases, I would argue that there's a possibility. And so if we look at a randomized controlled trial published in the New England Journal back in 2015, they used a various range of weight-based dosing in pediatrics to allow for the various ages from 1 milligram to 2 milligrams to 3 milligrams per kilogram for these patients, and over a trial period of 6 months looking for efficacy. And they found this to be efficacious at 88%, those being treated with propranolol versus the 5% placebo. And so if we move away from hemangiomas and say, well, where are we with cavernomas going forward? It's pretty sparse with single cases initially going forward, with 2 adult patients with a presumed recurrent hemorrhagic risk reduced. A single patient, very young, infantile, with a large cavernous malformation with a significant decrease in even 10 days after initiation of propranolol. And that's not too much of a surprise, knowing some of the literature of propranolol and its efficacy outside of cavernomas. If we look at even long-term use of propranolol, there's even single reports talking about growth arrest in comparison to growth when we follow natural history of patients presenting, pediatric patients presenting with cavernomas. And then even the idea out at Colorado, where they had a single patient, pediatric patient with a ruptured brainstem cavernoma, where they evacuated the hematoma. There was some residual cavernous lesion and managed on propranolol postoperatively, where there's MR evidence that nearly shows resolution of that lesion being said. So I think it gets to the point of how do we follow the effects of these trials going forward, the different treatment patterns. And so I really applaud a lot of the work going through the Alliance to Cure and through the Brain Vascular Malformation Consortium through the NIH for these biomarker studies that are both helpful, not just for adults, but also our pediatric patients that we're entering in here. I think it's very helpful to look at markers that going forward of different ways that treatment patterns can be introduced. So nonetheless, with propranolol, where do we go from here? How can we use this? And here at Cincinnati, I've begun to look at a little bit of a change in saying that our young patients, our brainstem cavernoma patients that present with a rupture, can we consider propranolol like we could have considered in the case of that patient that was presented with both a lymphangioma and then also the brainstem cavernoma? If that were to happen here, could we consider propranolol? Is it possible to have a hemorrhagic presentation with a delay in recurrence of rupture in between that first to second rupture? Should we wait for that second rupture, or should we wait for that third or fourth in the idea of approaching this surgically with less risk going forward or better outcomes? It's hard to know. But there are significant studies that are happening internationally, and they're great studies moving forward. However, there's still, nonetheless, at the end of the day, still equipoise with the idea of propranolol and its use for cavernomas. And so at this time, still not the recommendation quite yet, but great information going forward. But how do we know, much like the patients have asked me here, how do you know this is just a blood pressure medication? How do you know it's just not reducing the blood pressure and that's enough for this lesion not to rupture? And simply thinking that that might be the case, but when you look at seminal work here, published in the Journal of Clinical Investigation and also through stroke, through the American Heart Association, we can see that even in mouse models that are well controlled here, that we can identify that the lesion themselves are much smaller in size and the multiplicity of them being less. And then if we look at a microscopic level and look at the cellular components, we can see even from a structural stability standpoint of endothelial cells within the cavernomas and the supporting matrix around this better preserved with the addition of propranolol. So we think that even in controlled bench side studies for the receptor, not necessarily the pressure, we can identify a role at the receptor level. And so we think that from a molecular standpoint, there is some evidence growing. But does this translate well to clinical practice? It's hard to know. And so what we're trying here is the idea of, in these extreme examples where we're looking for a source to help us going forward, propranolol may have a role moving forward. So here I want to share just a couple cases that I've isolated that I think bear some important points of all of them. And so number one, here's a 3-year-old who presented here with repeated brainstem hemorrhage approximately 10 days apart in an outside hospital. Had a progressive decline initially, cranial neuropathy, symptom, come back with repeat hemorrhage, worsened progressive exam towards needing ventilator support, complete weakness in all four extremities, limited cooperation with exam, and concern for even palliation at that point. Is there any role of going forward? There was consideration from that outside neurosurgeon to transfer here and here for surgical care. And once arrived, you can see that initially, the initial presentation was much smaller, but still a pontomedullary brainstem cavernoma with rupture evidence. And then going forward, approximately a week later, nearly doubled in size from 1.5 centimeters to just over 3 centimeters. But what does this really mean? Do we go forward immediately with surgery? You can imagine the hard conversation I had with the family when days, hours, minutes, seconds of watching their child on a ventilator can be detrimental. And how do you know if another rupture is going to happen when it already has been happening? And we know that cavernomas can have what you've already heard from those like Dr. Smith, Dr. Lawton, Dr. Awad, talking about this cluster effect of hemorrhages and beautiful surgical approaches that are trying to get to these roles without disrupting the brainstem or the brain itself. And so when we look at this picture, I want to show you a little bit about this cavernoma. And going back to the example of being punched in the eye and the swelling effect, we want to say, well, we can try and get to this cavernoma in the most minimally invasive way, the safest or least risk way of safe entry zones going forward, and selecting in patients that have features of how well they can do long-term going forward. But what are we really doing with the cavernoma itself and its hemorrhagic presentation? And is there a role for a molecular adjuvant to help us surgically going forward? And so the thought was here, it was a hard conversation to say, well, I'd like your child to be on Propranolol and wait. And they've already been waiting and have presented with a re-rupture. But going forward, even a short period of time to try and get them into a subacute phase, we'd love for this, as a surgeon speaking, for that hematoma to really liquefy. We'd love for that blood to be really thin, much like Kool-Aid, and not much like the thick consistency of a Jell-O pattern, where things are more sticky and needing to piecemeal or pull out or cup out pieces of the cavernoma. Sorry to be crude to the audience in that sense, but it's much easier to go in and be able to suction out more of a liquid effect, and especially in an infantile and a very young presentation where surgical time and blood volume loss are quite important going forward. I want to point out a picture here, if it's okay, looking at the brainstem and the cranial nerves nearby, and without getting into too much detail, the idea of being able to look at a safe entry zone of entering to get in when not always do we see that cavernoma express itself or show itself right off the bat on the brain or brainstem. But once we get inside, is it a way that is liquefied where there's less manipulation, much easier to suction out and remove this cavernoma quickly without taking too much time or much blood loss going forward? So I think that there are roles for medications to help us from not re-rupturing and allowing us time for a safer approach with our surgeries, at least anecdotally so far. So with that being said, here's a pre-op picture and the classic post-op picture where things look much better, and the patient also having outcomes that I believe are much better on follow-up moving forward. What are some of the, I want to pause here and say, well, if we consider therapies like this, what are we looking for during that time with propranolol? Are there side effects that we should be considering? And they're numerous. Even though it's well described from an antihypertensive medication in the adult literature and in clinical practice, and at the same time with young patients with hemangiomas, we know that they can tolerate it quite well. But nonetheless, what could we see in our pediatric patients? We might see diarrhea, sleep difficulty, irritability. And I put a green box around this and really underline diarrhea, because that's the one that we've seen with our patients predominantly. And and I'll tell you, it's an easy thing to get around. We have patients that are admitted, they're on stool softeners, And going along with propranolol, it's not a surprise that diarrhea might be a concern. But once those stool softeners are lessened or reduced, we find that that's much well controlled. Sleep difficulty, irritability in our young patients is always difficult to say that that's related to propranolol use or the idea of being in a hospital nonetheless. Hypoglycemia, reduced heart rate and blood pressure, we don't see it to be a common side effect. And I'll tell you, we don't really see it to be a significant concern. Cool hands with centripetal vasoconstriction, and even the most common intolerable side effect reported, bronchial hyperactivity. If we see that, it's reported to consider alternative beta blockers in use outside of cavernomas. And we haven't seen that. We know in the growing literature for traumatic brain injury, there's ideas of looking towards atenolol or metoprolol or even prednisolone from a steroid standpoint. Contraindications where it should not be used: sinus bradycardia, bronchial asthma. But nonetheless, we found very little in regards to side effects going forward in the short-term treatment prior to surgery. Here's a second case, and the reason I selected this case is the obvious question of, does it really matter between solitary presentation versus a familial cavernous malformation presentation? So here's a 16-month-old that presented similarly with a rupture of a brainstem cavernoma at an outside hospital and a re-rupture where this has grown quite large. Was then transferred into us for a surgical opinion and consideration towards surgical resection. You could see the multiplicity of cavernomas in a single cut there, along with their brainstem cavernoma here that has increased in size, and as well put them on propranolol and had the hard conversation of saying, please, let's wait, let's try propranolol for a few weeks, and then go on in the subacute phase of resection of this brainstem cavernoma. And moving forward, again, having a preoperative picture and a postoperative picture, you can see here how we came along in a similar fashion to the prior case, coming along the side of the brain to a surgical corridor that you've seen with webinars well laid out with Dr. Lawton and Dr. Smith, showing how we can get in eloquently into eloquent areas such as the pons and being able to resect this cavernoma and have great outcomes. But one of the reasons I've put this picture here is the nuances for pediatrics. When we look at pediatric brainstem cavernomas, we also have to think about, particularly in the very young, the 3-year-olds to the 3-month-olds, that hydrocephalus is a concern, too much water on the brain, meaning blocking of that CSF pathway. The idea of our venous system as we're shunting, we're born with a development where we're dependent on a lot of shunting anteriorly and then shunting of our venous blood through our dura, through our bone. So blood loss is a big concern. And how can we do a surgical approach where we have a bone flap here to open up some of the CSF spaces that allow our brain to relax and move out of position for us so we can sneak behind without going through brain tissue and get into locations to have a great resection with very little manipulation of the brainstem, and not only just during surgery, but then even after surgery. How can we allow that brainstem to be very well relaxed to recover to the greatest capacity going forward? So we think that allowing that blood within that cavernoma after that rupture to liquefy, to be thin, to allow for a sooner time point within surgery, meaning less surgical time. The idea of a relaxed hematoma that allows us to remove this with minimal blood loss, and surgical strategies that allow us to relax that brain afterwards from the swelling effect, much like being punched in the eye and controlling for the edema around. One question that when I presented this to our multidisciplinary team here, and we talked about the strategies going forward, you might say, well, is it really a hematoma around the cavernoma, or is it really a cavernoma that's bleeding within itself, getting larger? And I would say either which way, the idea that the cavernoma has blood inside and rupturing within itself, it's the idea that that blood we want to liquefy. And sometimes it just takes time without re-rupturing, that we want that blood to liquefy and have an easier route and a quicker route to removing this lesion. And so that's still a point of debate going forward, but at least anecdotally, in our experience here with a number of brainstem cavernomas, and trialing propranolol, I think anecdotally we've had success going forward. So something to consider nonetheless as growing literature from our pediatric patients. So adjuvant therapy, assisting therapy here. Hemorrhagic presentation may benefit from propranolol treatment as an adjuvant or an assistant to surgical therapy, and that may be in terms of rehemorrhage burden. So can we use the trials going forward with the biomarkers that are appropriate for looking at hemorrhage burden? Can we look at the liquefied clot? Is there a way to identify the benefit of a thick or gelatinous hematoma within the cavernoma versus a more liquefied cavernoma? And is that something that can be of benefit with propranolol treatment rather than instead of surgery for these detrimental presentations? We've seen it, I'm talking about it before, but even post surgical resection or post hemorrhage without surgery, it's still an unclear anecdotal benefit going forward, but multiple studies out there trialing and having great interest in propranolol or this molecular route. And there's still nonetheless equipoise in its use, but as well with solitary versus familial going forward. And that's why I picked out those two cases, one of a solitary presentation in the very young and a familial in the very young with similar presentation parameters. I think pediatric considerations with adjuvant therapy is important. We think that the blood-brain barrier penetration of propranolol is quite good, being a non-selective beta-adrenergic receptor medication. We can see a lot of this similarly in the traumatic brain injury literature as well, outside of malformations. We think that residual recurrent cavernoma reduction post-operatively, if there is a residual, let's say there's a hemosiderin ring that's not safe to take, and the role of second look surgery may not be needed even post-operatively if that's the case. So is there a role there as an adjuvant? It may allow for preoperatively a subacute phase operation. Maybe after that first bleed, are we really waiting for that second bleed? Or are we allowing propranolol to take effect if surgery is needed? Can we make that blood a little bit more surgically amenable if necessary? Pediatric surgical approaches, I think I talked about with the cases, venous anatomy, cerebellar drainage. I think the surgical approaches vary between the very young, meaning less than 3 years, to the childhood age, to then even our preteen, teenage, and young adult age groups versus our adults. I think there's variation there. And time and minimizing blood loss are extremely important. I think you heard that from Dr. Smith as well, that caveats towards controlling for venous drainage through the bone and the dura is quite important even in the very young. With that being said, I want to move towards not necessarily can we do better, not necessarily how we can do better, but can we do this all together moving forward? So I do want to kind of wrap this up a little bit with some of the work that we're doing here at Cincinnati and kind of our research perspective as a team moving forward. And can we think about the molecular adjuvants towards ruptured brainstem cavernomas, and how do we model that and be helpful for everybody? So another model that we're considering here, and if you guys were at Miami at the national conference, you might have seen a little bit of this work presented there by Dr. Dow from Dr. Gao's lab, and with the work from our lab in combination, we can see here that we can take human stem cells and induce them into both brain or neural tissue and vascular tissue. And can this be represented in a culture? Meaning a little dish and a grouping or organization of these cells into a little assembloid or organoid going forward. So they have resembling features much akin to a blood-brain barrier, but when we take a healthy individual versus a cavernous malformation individual and look at this approach to organoids, we can find that these models, these assembloids, have features that are very similar to cavernomas themselves. And then when we compare surgically resected cavernomas, both familial, solitary, and look towards features of cavernomas, we can identify that we've put together a human cerebral cavernous malformation organoid going forward. So a lot of this work that you saw preliminary and even here now is work that you're going to be seeing very soon in published print. And why we see this is that we see very similar disorganization of normal endothelial cells in vascular patterns or vascular networks into this disorganized network. And then even the supporting matrix around these cells are very well disorganized in our cavernous malformation groupings versus our human brain developed stem cell organoids going forward. So again, we think that there's a lot to learn in models looking at development of cavernomas, a lot to learn from our pediatric patients that are going through development, and not only through their experience of having a ruptured cavernoma or the response to treatment, but even learning from how they report things from their eyes. And so I highly encourage you to really obtain a copy of this book going forward about Juju and her story from her family's perspective and her perspective. And I'm hopeful that all together we'll discover things much like this grass soup, using the environment around us and the tools around us to gain more experience and learn from the ideas of its use going forward. So molecular adjuvants for pediatric brainstem cavernomas. I'm lucky to be part of a large team here. Those of you that are familiar with the Cincinnati area have been around. I'm sure you've met with Dr. Taylor, our nursing staff with Megan and physician assistant Tim, and our program coordinator Celia, and our research assistants and many within our group going forward. So I think here I'll end on this last slide, talking about the idea of how can we learn from each other. We have a local get together where every August, if you're interested in baseball and would like to come watch the Cincinnati Reds or root for your team coming to play the Reds, we put together a little patient family education conference. And this is not meant for us to be ones to present to you, but an interaction for all of us to put together a fun outing where we talk about different cases, different cutting edge research, and then enjoy things together, such as baseball out at the ballpark. So again, Connie, thank you very much for inviting me to give this talk. And I'll end here and take questions if that's okay.
Yes, that would be perfect. Thank you so much. Can you take your slides down, and then I'll start grilling you with some of the questions that people have been dropping into the Q&A. And again, sure, folks, if you have a question, please use the Q&A. We have folks who are thanking you for being here, sharing a little bit about their stories, but very grateful that you're here to tell what you're doing, and also the fact that you're doing it is very important to them. One of the first questions on propranolol is, what happens if you see the lesion increase in size while the patient is taking propranolol? Do you continue to offer propranolol, or do you withdraw it at that point?
I think the presumption would be to continue. The idea is that we're not necessarily seeing an enlargement of that cavernoma. At least we're not seeing that. There is ideas that the rupture or the hemorrhage within that cavernoma may change shape, but the overall volume or the pressure effect. So I want to go back to, and I'd say my kids tell me I'm full of bad examples, so I'm sorry. But being punched in the eye and that swelling effect around, is that swelling effect or that pressure lessened? So I guess the idea would be to say, I'll answer that question in twofold. One way is to say, we're not seeing that the cavernoma is enlarging, but I would presume that we would want to continue nonetheless. And the goal would be, is there a pressure effect that's increasing? And if we're not seeing that, where it's causing us to then go forward with surgery more immediately, then it may be okay to continue. So we have not seen that enlargement happening from a pressure or lesion effect.
Okay. A technical thing. I think we're still seeing your desktop right now.
Oh, I'm sorry. Let me stop sharing here.
Yeah.
Maybe that's better. Is that okay?
Not yet. It may be the other screen that you were using. There you go. Got it. All right. Now we see each other good.
Okay.
And so I'm going to follow up with that. And so you're offering the propranolol during the time between the hemorrhage and the surgery. You mentioned that in one case study that was written up, the propranolol was continued post-surgically. Is that something you're doing right now too, or do you stop?
Yeah, so the best literature I can follow is the Treat CCM work that's being done out of Italy. And at the same time, the New England Journal of Medicine and what's being done with our hemangioma vascular malformation group with extracranial hemangiomas, which is that 6-month period. So we're putting them on or starting after that hemorrhagic presentation. And no matter where surgery falls in line, we're trying to keep them on for the 6 months and look from there. So again, the idea is not necessarily to take a strategy from a medical therapy and say, this is preventative versus surgery. It's to say, how can we look at propranolol in our severe cases and still go on with the standard of care if they need surgical approaches? Can this be helpful to surgery? And I think we're having a glimpse that it could, but I say it could, and that's not something that's standard, at least not now.
Okay. And then we have folks wondering about adult patients, and is there a way to encourage surgeons in the adult world of surgery to do the same thing, and how would you go about that?
I'm always weary of that question. I think that the Alliance to Cure does a great job of putting everything together, and there's not a more centralized resource that I can think of worldly, where research and clinical practice comes together for patients and education going forward. I think, I've heard Dr. Awad talk about this a number of times, saying that we really need to be an organized institution to be able to go forward with trials. And part of it is just understanding what are the best biomarkers to really evaluate treatment strategies going forward. And sometimes when you have the rarest of rare cases and you're trying to put together trials, but there's a number of avenues for treatment, it gets really hard to accrue the right numbers in a nuts and bolts scenario of conducting trials. So we have great literature to suggest that things look very interesting and promising, but how can we take it to the finish line really means we've got to isolate into certain strategies that may be very beneficial. So yes, I would love to have trials that are numerous, much like some of the other medical problems that are out there that are so numerous that we can enter into a number of different trials or have choices of trials. But sometimes it's the best efforts and the most well-organized trials going forward that we can bring patients, whether adult or pediatric, together. I'm going to answer also on a tangent and say that I'm a pediatric provider. My specialty is on pediatric patients, and I would love a trial for pediatrics to jump into. And we're lucky right now to look into the biomarkers study. And so I think that's great. And we're entering in our patients, and they've been doing a great job going into this. But we're also hopeful to take things into translation here as well. So I'm hopeful that that's the case. But there's numerous factors that go into it. And I think places like Alliance to Cure is extremely important to follow.
Okay. And the follow-up question is one that was actually asked before that, which is how and when is research shared among medical facilities? And I'm going to read more of what she wrote just so that you get the context. I understand the need to keep research proprietary and or develop a given medical facility's ability to stand out from others. At the same time, information sharing is pivotal, whether it be for diseases everyone is looking for, such as cancer or rare diseases. Patients deserve the best up-to-date info, no matter where they are. So how can you just share from your perspective, and I can share a little bit from my perspective, how is it that research gets shared? How early in the research process do you learn about other people's work?
I agree. I agree 100%. How can we as patients and families be up to date to take that hat rather than a surgeon's hat, and say that we want to always be familiar with things that are going on, to be educated, but not necessarily have the ability to say that, yes, this is the best way versus not. I think we're always looking for education going forward. I think the best way to share that I see, if we were to take different medical problems and say, which avenues or diseases are really propelling research. And again, I would applaud Alliance to Cure to have things like this webinar, to have national conferences that allow families and patients to attend, and not just the physicians and researchers to discuss amongst themselves, I think is one way to bridge that gap. Another thing that I applaud the Alliance to Cure is this webinar. I think you're seeing here, I even mentioned some of the slides that I presented from our organoid research. That's not out in print, and that's a little bit of a risk to be able to say and put that out there. But with Dr. Gao and myself, we're very strong in our pursuit and very confident in our research. And we think it's important for those of you to know what's happening, to know that there is cutting edge things that are happening, and it's not revealing it behind the curtains later on when it's a big show. I think it's important to know what kind of progress is happening, whether it's going to go to fruition or not, because I think the failures are important to learn from as well. I'm hopeful that answers your question.
Yeah, and I mean, I can add to that. When we have our science meetings, the scientists that attend and who present are told that the research that they present has to be either unpublished or very recently published. We expect that everybody's going to be sharing something new that nobody's ever seen before. So if they're at our meeting too, they are not allowed to share, take pictures of slides, share any of the data that they were exposed to. So this is one setting where you have to be there. If you miss it, then you have missed the information for the year. So in that sense, it's a safe space. And that's what we try to create as an organization, a safe space so that the work can go faster, collaborations can happen. By the same token, there is a peer review process, and that's really important. I mean, scientists could put whole bunches of garbage research out there, and what stops that from happening is that research gets peer reviewed. Other scientists look at these papers before they are published and say, this is bad, this is bad. Reviewer number, they're anonymous, reviewer number 1, 2, 3, 4, and 5. And I know reviewer number 5 is like a pain because he or she keeps sending more questions back or ask very difficult questions that may lead to having to do even more work. So until a paper has gone through peer review, we don't necessarily have the same level of confidence or faith in what's in the paper. Just saying. So we can share it, we can take it for what it's worth, but until it's been through peer review, we shouldn't bank on it. And even then, I mean, science is science, and we are always learning. We are always looking at new ways to approach things. So I will get off my soapbox there, but I think that our scientists are the most open group of scientists and the most collaborative group of scientists in that exist out there. I don't believe that scientists in other diseases work any more closely than our scientists have. And that again is because we have nurtured a community of trust with them. Okay, next question. Is there a big cellular difference between cerebral cavernous malformations versus hemangiomas? And are they caused by the same protein missing? The etiology of the two, or is it different?
That's a great question that I don't have an answer to for you right now. That's actually one of the things that we're looking at the bench side in our research studies. We have a number of labs that look at hemangiomas here, surgically resected hemangiomas to biopsies, and then even towards our own cerebral cavernomas that we resect, where part of it's going to the national studies, and then as well part of it staying here for cellular growth in comparison. So we're actively looking into this, but I have no data or answer at this time.
Okay. Do you think you're seeing less neurological deficit after surgery with patients that have been taking propranolol?
I'm not sure. I think from some of the markers, I think our patients are doing well, and whether that's like Dr. Lawton's talk on surgical approaches to brainstem lesions, to Dr. Smith's approach that he mentioned with minimally invasive to image guidance. The surgical strategies that we use are quite good. Talking about all these different things to get there. So is it really an effective propranolol on short-term use? It's hard to know with a few patients. We have I say a number or a handful of patients that we go forward with, but nonetheless, it's not a full study to be able to answer that question. So I do think we have patients that are doing quite well, and I think better than historical studies that I was presenting, but I can't tell you it's from propranolol, at least not at this time.
Question, does propranolol have any benefits for stable and well-behaved brainstem cavernous malformations as a preventative treatment?
I think there's some anecdotal evidence that certain lesions are reducing in size. We have a patient that did not have a surgical resection that, again, we see that lesion nearly gone. And this is a lesion that's 2.5, 3 centimeters, and it's pretty impressive, the dramatic reduction, even within, well, I dare say, 1 to 2 weeks. So again, it's hard to know, and I don't know the nuances between the particular cavernomas and their interaction with propranolol, much like the discussion I was alluding to during the presentation about hematoma within the cavernoma versus hematoma outside the cavernoma. I would love to answer that question in itself, but I'm hopeful. I'm very hopeful going forward.
Yeah. And I think too, when we get these questions, one of the things that we're not addressing is dosing. With propranolol, I know in some of the literature, the doses that have been used are quite high and not well tolerated by adults, in the adult population. And I'm wondering if you could speak to
Sure.
that a bit.
I would say that I'm emulating standard care with hemangiomas in infants. So if we're looking at 2 milligrams per kilogram, so that medium dose from the New England Journal, from 1 to 3, that 2 milligram per kilogram weight-based dose is what I'm using. There are times that we've seen that, yes, maybe the heart rate is a little bit lowered. Is it based on the pressure that's happening of that cavernoma? Is it based on the other medications? It's hard to know. But we've generally stayed on that 2 milligrams. I've not gone higher. We've had some adult patients that we followed the treat CCM parameters of the 40 and 80 and looked into that. But again, I'm predominantly pediatric, so I can speak more there. And we implement 2 milligrams per kilogram.
Someone just would like you to explain the term adjuvant.
Yes, adjuvant, I would say, is almost synonymous to assist. Whether it's before or after, we're hopeful that this approach of using propranolol is not separate from surgery, or surgery is separate from a medicinal approach. It's the idea that this type of medicine may be helpful to our approach either way, which is surgery going forward in this patient. So it wasn't that, I'll also answer that question with, for the two cases, whether propranolol was there or not. So for years ago, it was every pediatric brainstem cavernoma that was ruptured that came in, we were going forward, I would operate. Versus now, there's consideration of putting them on propranolol, and still we're going forward with an operation. So it's there to be an assist role, is probably the best way I can explain it.
All right. Outside of the propranolol question, do you and your team do second opinions? And if so, how would a patient go about starting that?
Yeah, that's great. Much like others, we have a website. We have our Cerebrovascular Center website at Cincinnati Children's. If you go there, there are a number of boxes that talk about second opinions that you can click on. It's very easy to upload information there. So it's very straightforward for second opinions. And that can also go through Alliance to Cure as well, both ways.
I am now checking the chat, and there's someone has asked a question in the chat that's quite long, and I'm trying to read through it. I have a 4.5-year-old boy who has a cavernoma in a brainstem, and he had bleeding 1.5 years ago. He has been on propranolol for more than 6 months, and it didn't help with decreasing in size. His doctor is advising intervention to remove it because it affects his ability to walk and mental and cognitive capabilities. I'm not expecting opinions or advice, but the question is, what is the best way to get opinions from all relevant parties that can lead us to make the best decision on this?
Yeah, I think similar to the previous question, I think the second opinions is a great way, even if you were formally asking over a webinar, I would say that it's very difficult without seeing your child and then looking at all the information that's important that can actually be partially given through a second opinion, to the point of actually seeing the patient as well. So I think it'd be important that way. And so I think getting information through a second opinion service is probably the best route to get information there.
And I'm going to ask the rest of his question then. His dream is that there could be a panel of experts and that patients could just send their case to the panel and not have to chase down every individual center of excellence. What do you think?
I think it's a great question. And I think that's already what's kind of happening with Alliance to Cure. You know, without this organization, I would say, as a father myself with kids, you know, if we're looking for information, it's just us on our phone or websites searching for hospitals and trying to find the individuals. But when you identify an organization that's already selected centers of excellence that have experience, and then those, whether they're adult or pediatric, and narrowed it down for you, it makes it very easy to have a panel of experts to go to immediately. So I think that that's there through the Alliance to Cure. So I think that's the route that's happening already.
And I do want to say too that there are some facilities that have joint case study, like case reviews. So I believe that Boston Children's has a partner hospital in England where they do case reviews together. So the Mayo system, there are 3 different Mayos, and they review the CCM cases together. So you can get multiple opinions out of one second opinion, choosing the right facility. Do you guys work with anybody? Do you have the University of Cincinnati, right?
Yeah, through the organization of Cincinnati Children's, there's an outreach of multiple sites. So I guess the arm length away, the number of institutions involved, yes, with other pediatric hospitals. So there's a consortium that way that we review. So in typical, that would happen. But I wouldn't say that there's a formal relationship with a single center that's separate from us.
All right. We are pretty much out of time. Darla, can you drop the support group link in the chat so that folks have a chance to access it? She had it right ready there. The support group link is in the chat right now. So before I shut down the webinar, you will need to click on that in order to get it or copy and paste it. Dr. V, thank you. Thank you so much.
Great. No, thank you.
Fascinating. And you were just pushing the field ahead in ways that we couldn't have imagined, or I couldn't have imagined even a year ago. So
that's great.
I'm so
thank you guys. I really appreciate your time and everything. And if you get a chance, please take a look at that book. I think it's amazing.
We will. Okay. Thank you.
Sure.
Thanks.
Bye, guys.